Claire, let's touch on another topic. So, we've been talking a fair bit about critical ischemia, but as you well know, there's a whole other subgroup of symptomatic patients that have claudication. Um, what are your thoughts about, how aggressive you are with a patient, what you're thinking the first time you see a claudicant in your practice? What are the different options in terms of treatment outside of revascularization? Give me your thoughts on that.
My first thought is really to gauge how much it's really impacting their life to have this type of symptom. Somebody who notices it but is able to do all of their daily activities, all of the things that they want to do, is somebody that I'm not inclined to be particularly aggressive in their treatment as far as like going towards surgery. Because certainly no surgery is without its complications, and you can always make things worse if you aren't careful. So step one is really, is this impacting your ability to work, your ability to engage in the activities that for you really make your life happy and worth living the way you want to live your life. The second thing to consider is where that disease sits sort of in their global picture. So is this somebody who is managing their other medical comorbidities appropriately? Are they, on appropriate diabetic medications, hypertension medications? Are they on a statin? Do they still smoke is really a big factor, because we know that smoking is a huge risk factor for progression of disease and for them not having as good outcome as you'd like. And then beyond that, I think before you would really consider surgery for someone like this, encouraging them to take care of all those comorbidities and to start regularly exercising to try and to address their symptoms in a more natural way before you have to do an intervention on them is ideal in order to maximize their ability to regain function with minimizing their risk of causing a complication.
Yeah, no, that's a great answer. It really highlights all the factors that we need to consider. I'll just say it was a real kind of victory for the field, and a real testament to the doggedness of our vascular medicine colleagues who were able to get CMS to approve payment for walking programs. So a standardized exercise walking program is now reimbursable, and that goes a long way. There's still a real shortage of programs to refer patients to, and that's a real problem, but it highlights the importance of kind of first line care being risk factor reduction, as you talked about, second line therapy, a real walking program, and only if they have really failed that, consider more aggressive therapy. The downside being, you intervene on someone and a year later, 2 years later, you could have that patient returning with a more advanced form of disease, rest pain, or heaven forbid, tissue loss. The natural history of claudication is relatively benign. There is a school of thought that says, hey, if we can get them walking, then that's better for their overall health, that's better for their heart, and those are real considerations. But I think, you highlighted the things that we think about.